Hello, this is Eric Ruderman from Northwestern University in Chicago, coming to you from the EULAR meeting in Milan for Room Now. I was tasked to look at some of the psoriatic arthritis abstracts at this meeting, and one that I found particularly interesting was abstract 68. It was an oral presentation, 68, and it looked at the concept of central pain in psoriatic arthritis. So what is that? I think we've learned over the last 10 years or so that regardless of which of our diseases we're treating, whether it's psoriatic arthritis or axial spondyloarthritis or rheumatoid arthritis or lupus, that somewhere in the neighborhood of 20 or 30% of our patients are going to have pain that's not really driven by inflammation. In the past, we would just attribute this to fibromyalgia, but it's not as simple as that. And it's really just sort of a centrally mediated pain that may in fact be part of the disease. But the key point of this is that it is not going to respond in the same way that inflammatory symptoms are going to respond to a lot of the treatments that we use. So this particular abstract from a group in Turkey looked at a cross-sectional study of 114 patients with psoriatic arthritis to try to understand how much this issue of central pain impacted the outcomes of their treatment. It was cross-sectional, so they didn't really look prospectively at what happened with treatment, but when they looked at these folks, about 68% were women, 22% had fibromyalgia using the ACR criteria from 2016, and 40% were taking biologic therapy. They assessed their disease activity and their level of function using a HAQ score, and then they administered something called the Central Sensitization Inventory, which is a questionnaire which really predicts the likelihood that that particular patient has central pain. The higher you score on the questionnaire, the more likely that some of the symptoms you're having are centrally driven. And in fact, in this group, 43% had a high likelihood of a lot of central pain using the cutoff that they looked at. But what was most interesting is that when they then took those central pain numbers or the numbers from that central sensitization inventory and compared them to a patient global assessment, the physician global assessment, a composite endpoint, the DAPSA, the health assessment questionnaire, the HAQ, in each case, the higher you scored on the central sensitization inventory, the worse your disease was. And the takeaway is that we really need to consider this as we think about how our patients are responding to the treatments we give them. And it's really important because if you have a patient who's doing poorly and you're trying to use an objective measure, or at least a theoretically objective measure to identify their response to therapy, and you don't account for this, you're going to say, well, they haven't hit that measure, and so we're going to have to change therapy, when in fact, that's not going to make them better. You need to address this central pain issue if you really hope to make their disease any better, at least make their symptoms better. There was another abstract at this meeting that looked at axial spondyloarthritis, radiographic axial spondyloarthritis, essentially AS, in a German registry that showed very much the same thing. This was a poster, I think it was 299. And again, they use a different questionnaire, the so-called widespread pain index, which really quantifies central pain. And they found much the same thing, that residual symptoms in patients who'd been treated, which meant a higher composite score, they used the ASDAS score, was attributable to the central pain and it was independent of inflammation or other sort of more objective measures. They use CRP for inflammation. So how do we use all this? Well, there's a couple things. I think we need to think about this in our patients in practice and recognize that there's likely to be a component of central pain in a lot of our patients. And if we don't address this, we're not going to make them better. We're not going to really treat their disease properly. The other piece of this that I think is important is that we have to consider this going forward in clinical trials, because if we recognize that this is a big issue, you really have two choices in clinical trials. You can try to eliminate these patients from the study, because then this issue of central pain won't affect their response to whatever drug therapy you're testing. But the problem there is that you're going to have these patients in practice, so the trial results may not be reflective of what you might expect to see in practice. Or you could consider including these patients in trials, but then you're going to have to account for this pain and perhaps stratify them by the level of central pain they have to try to understand if there's a differential effect of the treatment that you're studying on their overall outcomes when you sort of include this central pain piece and account for it. So interesting issues and something we're going to have to think about. Stay tuned here for more interesting abstracts from Room Now in the coming days.